Okay, hi everyone. We're going to get started. My name is Dina Rucco. I'm one of the pharmacy residents this year, and our topic today is spinal muscular atrophy. We used poll everywhere today for the live ones. You can feel free to join again. If not, you could always type in the answers for questions throughout in the comments or the chat during our Zoom. Or you can join in if you want to. I'll give you a couple of seconds to join if you prefer that. This will also pop up again when the questions come. So just to continue on, for author disclosures, I have no financial interests or affiliations or conflicts of interest or anything. If I use any brand names, it's for identification and for ease of speech purposes only. So our objectives today are to define the pathophysiology of spinal muscular atrophy, identify the different types of spinal muscular atrophy, review current treatments for spinal muscular atrophy, discuss the use of onosegmagene abeparavec, and describe vector-based gene therapy. So before we start, what is spinal muscular atrophy? I have a YouTube video here to kind of give you a actual face to the disease before we dive into the actual mechanism behind the disease that I will play for you now.
Do you wanna sing a song, Brett? My name is Paige Kingsley, and Brett is my brother. Brett has spinal muscular atrophy. It means that weak muscles throughout the body. Brett loves to watch movies. He is very into sports. We play outside. We go down to the ducks, and we also read books to him. Holy salami! That goofy cat's just making things worse and worse. He laughs. He communicates through the Dynavox. Paige, I love you. Oh, I love you too, Brett. He's the class clown.
Did you see my video?
I did. Are you kidding?
I'm pretty cute, don't you think?
Won this marathon, and seeing him cross the finish line let things know that impossible can become possible if you just believe.
What's your favorite thing?
I would have to say being with my family. Rudolph the red-nosed reindeer had a very shiny nose. I hope that there can be a cure from Nationwide Children's Hospital. If you donate, it's nice to know that there's a community service right around the corner, and it knows that the money goes there.
So that's just a little video to kind of put a face to the disease before we actually dive in. It's kind of heartbreaking to see, but this does plague a few families and individuals in the US, so it's kind of good to see the actual face behind the disease. So what exactly is happening in the disease? So in a normal brain, when you want to make a muscle move, the brain sends a signal down an upper motor neuron to the spinal cord, which then transport the impulse to a lower motor neuron, which then goes to the muscle. The lower motor neuron is actually what is dying off in spinal muscular atrophy, and this is what's going to help control voluntary muscle movements. So when the motor neuron dies, the neuromuscular junction dies. That motor unit, which is the neuron and the muscle fiber, stops working, which eventually leads to muscle weakness and paralysis. The muscle also atrophies due to no innervation from the nerve. This is the classic use it or lose it situation. And then if enough junctions fail, this can cause fasciculations or spontaneous and involuntary contractions. And these patients also lose their deep tendon reflexes. So spinal muscular atrophy is the rare autosomal recessive inherited progressive neuromuscular disorder that results in muscle atrophy. It is rare, but it is the most common genetic cause of death in infants. It requires 2 gene flaws, one from each parent. So it's actually caused by a deletion of the SMN1 gene, but you need one from each parent. If you just have one gene flaw, you're considered a carrier. You won't show any symptoms of spinal muscular atrophy, but you are a carrier of it. And if 2 parents are both carriers, the risk of pregnancy resulting in a child with the disease is 25% with each pregnancy. So the mutation itself leads to a deficiency of a motor neuron protein called the SMN, or survival of motor neuron. So our first question here is, what is the prevalence of spinal muscular atrophy? You can, if you joined the poll everywhere, you can put in an answer, or you can just type in an answer in the chat. I'll give you a second to do that. Yeah, so actually, it is actually 1 in 10,000 births results in spinal muscular atrophy. So that's just to give you a little perspective of how rare it is. So to compare a healthy individual to an individual with spinal muscular atrophy, a healthy individual has the SMN1 gene, and they're able to produce full-length, fully functioning SMN proteins. An SMA individual has no SMN1 gene, so they cannot produce the SMN gene. But in both a healthy individual and a spinal muscular atrophy individual, we have SMN2 genes, which is a pseudogene. It's actually 99% the same as SMN1, except for deletion of exon 7. So this causes SMN2 to produce SMN proteins, but only about 10 to 15% of them are actually functional. And everybody has multiple copies of the SMN2 gene, and it varies. You can either have anywhere between 0 to 8 copies of the SMN2 gene. The more SMN2 gene copies a person has, the more functional SMN protein is available. So what exactly does the SMN protein do? It's actually expressed in all cells. It's a component of the spliceosome, which cuts introns out of pre-RNA, and introns are just the segment of DNA or RNA that does not code for proteins and interrupts the sequence of genes. So that needs to be cut out in order to have the exon that actually codes for the protein we're looking for. SMN protein also blocks caspases, which are involved in apoptosis. So a lack in the SMN protein may actually enhance apoptosis due to no blockage of the caspases. And then SMN protein has some influence on the alpha motor neurons, which I've mentioned before are what's actually dying off here, but the actual mechanism is unclear as to what exactly SMN protein does to maintain motor neurons. So now we're going to go over some of the types. There's actually 4 different types of spinal muscular atrophy, and the difference depends on the age of onset, the phenotypic severity, and the higher motor milestone achieved. So type 1 is the most common and most severe. There's 2 subtypes. Type 1A is congenital spinal muscular atrophy. It's actually diagnosed in the womb. Mothers will start to notice that they will have decreased fetal movements, or they can be diagnosed through genetic testing. This type is, if the baby makes it to full term and is delivered, it's usually fatal within a few weeks to months. They have 0 to 1 copies of the SMN2 gene. Type 1B is infantile spinal muscular atrophy. These patients are diagnosed anywhere between 0 and 6 months old. These patients are normal at birth, but then they will start to develop hypotonia, which is low muscle tone, and it's more obvious in the legs, making them unable to sit up. That's why they're considered non-sitters. Then they will start to develop weakness in the muscles involving the sucking, chewing, and swallowing, and this will make it difficult for them to take milk or to eat, which it might be noticed from the parents and might first spark their need to go to the doctor and get them checked out. They also have difficulty swallowing their own secretions. If you remember back to the video, Brett had a lot of secretions on his face, and this is a very common picture for patients with spinal muscular atrophy. It also increases the risk of aspiration. They also have weakness in their chest wall and diaphragm, making breathing difficult, and also can lead to respiratory failure. These patients, if not treated, only survive a few years. Most of them won't even make it to their 2nd birthday. Types 2, 3, and 4, as you go up in the type, you actually decrease the severity. So these patients usually survive into adulthood. The type 2, their highest motor milestone is they will be able to sit. Type 3, they will be able to walk, and type 4 is considered adult onset. These patients are usually diagnosed in their second or third decade of life. But like I said, these are less severe than type 1, and these patients will survive to adulthood. These are some of the signs and symptoms of spinal muscular atrophy. I kind of went over them a little bit, but these are for your reference. Just aside from this, there is a blood test for creatine kinase, which actually leaks out of muscles that are deteriorating. This is a non-specific test because these levels can be elevated in many neuromuscular diseases, but it's often a useful test because it does indicate that there is muscle damage occurring in the body. So onto treatment. Before 2016, treatment was mainly supportive. Patients would need nutrition support through a feeding tube or respiratory support, but it's imperative to diagnose spinal muscular atrophy as early as possible, ideally before symptoms even onset, because any delay in treatment can worsen the course of the disease and create permanent damage in the motor neurons. So these treatments that we have are not cures. They just prevent further nerve and muscle degeneration, but whatever motor neurons are lost, that neuron will never come back. The best way to identify spinal muscular atrophy before symptoms appear is to screen all newborns for the SMN1 exon 7 deletion. So our second question here is what types of medications are currently available for treatment of spinal muscular atrophy? Again, you can text in the answer or you can comment. Yes, it's actually all of the above, and we'll get into all the current treatments that we have for the rest of my presentation. So the first medication we have is nusinersen, which was approved December 23rd, 2016. It also goes by the brand name Spinraza. It's indicated for the treatment of spinal muscular atrophy patients, both pediatric and adult. Dosing, it is given intrathecally. Patients will get 4 loading doses, and then after that, they get a maintenance dose every 4 months. So I put the price of these medications on my slides just as a reference to compare between these medications. This is costing $127,000 per dose. And to put that in perspective, for the loading doses alone, it actually costs over $500,000 and per year. So they will be getting it every 4 months. So that equals 3 doses a year. It's a cost about $380,000 per year. The way this works, it's an antisense oligonucleotide that increases exon 7 inclusion in the SMN2 mRNA transcripts to produce full-length SMN proteins. So like I said, these patients don't have any SMN1, but they still do have SMN2. So this helps boost whatever functional proteins the SMN2 gene can code for. It's actually a short sequence of RNA that binds just after exon 7 in the unedited RNA message. And this piece of RNA prevents exon 7 from being skipped. So now it's included in the edited message, which in turn will generate a full-length functional SMN protein. This was the first study that got this medication approved. It was a randomized, double-blind, sham-controlled phase 3 efficacy and safety trial in infants with spinal muscular atrophy. This study also went by the name the ENDEAR study. It had 121 patients in 31 centers. So the primary endpoint of this study was a motor milestone response. This was defined according to the results of the Hammersmith Infant Neurological Exam, which is an easy-to-perform exam that looks into 34 different items, usually assessing tone, motor patterns, observation of spontaneous movement, reflexes, and visual and auditory attention. The scores for this neurological exam range from 0 to 26, with higher scores indicating a better function. And specifically, they were looking at voluntary grasp, kicking, head control, rolling, sitting, crawling, standing, or walking. The second primary endpoint they looked at was an event-free survival. So they defined this as either time to death or time to use of a permanent assisted ventilation. And then the secondary endpoints were listed just as a reference. Their inclusion criteria, so these patients all had type 1 spinal muscular atrophy. They had the homozygous deletion. They had 2 copies of the SMN2 gene. They were all diagnosed and had symptoms less than 6 months of age, and they were all 7 months of age or younger at screening. And they did not have low peripheral oxygen saturation and met all other additional eligibility criteria. So patients were randomly assigned in a 2-to-1 ratio to either get the intrathecal nusinersen or the sham control, the sham procedure, which was the control group. The doses were administered the same way you normally would get the loading doses and the maintenance doses, and then the endpoints were assessed on the days listed here. So this study was actually terminated early because of the results at the interim analysis and for ethical consideration of the infants in the control group. So the primary endpoint, which was the motor milestone response, at the interim analysis, 41% of the nusinersen group had a motor milestone response, where 0 had it in the control group. And then they extrapolated this data for the final analysis because, like I mentioned, this study was terminated early. But they also saw that the no death or use to permanent assisted ventilation was seen in 61% of the nusinersen group and only 32% of the control group. They also looked at the CHOP in 10 response, which is just a similar neurologic exam. This is actually, CHOP in 10 stands for the Children's Hospital of Philadelphia Infant Test of Neuromuscular Disorders. They saw an increase in that scale in 71% of the nusinersen group and only 3% of the control group. So the findings of these studies were astounding and helps get this medication approved. On the right-hand side, you also see they graphed the event-free survival and overall survival for the control group versus the actual treatment group. And as you can see in blue, the probability of survival, event-free and just overall survival, was greatly higher in the patients who actually got the medication versus the patients who got the control. So this got this medication approved. The second drug that was approved is onasemagene abiparvec, or Zolgensma. It was approved May 24th, 2019, and this was approved for the treatment of pediatric patients less than 2 years of age. Dosing for this is in vector genomes per kilogram of body weight. It's a one-time IV infusion over 60 minutes, and the price for this one-time infusion is $2.4 million. The way this works, it is a recombinant adeno-associated virus vector-based gene therapy, and this actually is giving back a copy of the SMN1 gene that these patients don't have. So the way this is given, on day 1, patients will come in and get equivalent to oral prednisolone at 1 milligram per kilogram of body weight, and they'll continue this for 30 days. Then the patients come in on day 2, and they will get the Zolgensma infusion, just the 1-hour infusion, and then they continue with their steroids for the rest of the 30 days. At the 30-day mark, they will come in to check liver function. So if they have unremarkable findings and the liver function tests are within normal limits, they will then begin a taper of their steroid over the next 28 days, and then they're finished with their treatment. They will continue on with check-ins, monthly check-ins for at least the first year, just to assess their response to the medication and see if they are improving with their motor milestones. If they come in at day 30, though, and their lab functions if there's any abnormality in their liver function, they will continue the systemic corticosteroids until the findings become unremarkable, and then they will taper the corticosteroids at that time. If they don't have any response, this is when a higher level of care will be implemented to deal with their liver function. So to dive into what gene therapy really is, it's an experimental technique that uses genes to treat or prevent diseases. It's understudied to make sure it's still safe and effective, but it's currently being tested only for diseases that have no other cures. So this includes inherited disorders like spinal muscular atrophy, but also some types of cancers and certain viral infections. We are inserting a gene into the patient's cells either with drugs or through surgery. So the reason that we would do that is if we are trying to replace a mutated gene that's causing disease with a healthy copy of the gene, or we might do this to inactivate a mutated gene that's functioning improperly, or to introduce a new gene into the body. So that's actually what we're doing in spinal muscular atrophy, because these patients are lacking that SMN1 gene. But the question is, how do we actually get the gene into the body? You need some kind of vector to get it in there. So viruses is what we have studied and what Zolgensma actually uses. So viruses are made up of genetic material packaged into a capsule, and they need to infect a host in order to reproduce. So this is exactly why researchers have used viruses as vectors. the natural feature of how viruses have to replicate in order to survive, make them the perfect vector to bring in new genes. So they will actually take out the virus DNA and put in the gene of interest, for, in our case, it's SMN1 gene, and then let the virus do its natural replication in the body and get incorporated into the chromosomes and the genes, and then the body will start replicating it. So I have on here on the left-hand side is just a list of some of the possible viruses that are being studied. As you can see, basically any virus has been studied. They study adenoviruses, adeno-associated, which is what Zolgensma is, herpes simplex virus, retroviruses, and then there's just different aspects and features of the drug which make them more ideal for different disease states, but I'll dive into exactly why we're using adeno-associated viral vectors. So these carry a small single-strand RNA genome. Adeno-associated viruses are small viruses that infect humans and other primates, but are not currently known to cause any diseases, which makes them the perfect one to study because we know there's no diseases that it's causing, so we'll just take its mechanism of replication and put in what we want. These generate low pathogenicity and toxicity and provide long-term transgene expression through chromosomal integration. The only limitation of using adeno-associated vectors relates to the immune response that is triggered by repeated administration. This isn't so much of an issue with Zolgensma as of now because it is only a one-time dose, and we try to fight that immune response by giving them those 30 days of steroids. But we don't know down the line, since this medication is so new, that we don't know if these patients will actually require a second or third dose down the line. But as of right now, this hasn't posed any issues, but something to keep in mind as these drugs hang on the market for a while. So this was the first study that actually looked into Zolgensma. It included 15 patients with spinal muscular atrophy type 1. They received a single dose of the Zolgensma, and they just split the patients. 3 of the patients received a lower dose, and 12 patients received a higher dose, which are listed here. So the primary outcome of the study was safety, and the secondary outcome was time until death or need for permanent ventilatory assistance. This study also compared that CHOP INTEND scale for motor function between the 2 cohorts. This CHOP INTEND scale, that was used for the ENDEAR study, it ranges from a score of 0 to 64, with higher doses indicating better function. Just something to note though, for spinal muscular atrophy patients, any score greater than 40 is unheard of. So they kind of kept that in mind because historically patients with spinal muscular atrophy rarely had scores at 40 or rarely maintained them at 40. So this was the first chart from the study, and this is showing the duration of survival free from need of permanent ventilation. The cohort 1 is listed at top. That was the 3 patients who received the lower dose, and cohort 2, which is the 12 patients who received the higher dose. And this is comparing, the colored mark is when they actually got the dose, and then up until they have a star, that's when they reach their follow-up after 2 years. The vertical green lines are showing historical studies of patients with spinal muscular atrophy before we had any treatment. So as you can see, at the 20-month mark, all of our patients in the study were still alive and did not need any permanent ventilation. But historically, the results from past studies, only at the 20-month mark, only about 8% of patients survived with a vent-free, free of permanent ventilation. So this study showed how giving this gene back to the patients has improved their lifestyle immensely. This second chart from the study showed the CHOP INTEND scores. So on the left is the patients who received the lower dose. On the right is the patients who received the higher dose. As you can see, that 40 mark has been marked on both charts. And the patients who received the higher dose, 11 out of 12 of them were above the 40 mark at the end of the study, which is unheard of for patients with spinal muscular atrophy. The difference here, both cohorts had an increase from baseline, but the patients who received the lower dose had a less of an increase at about 7 points, where the patients who got the higher dose had an increase of about 25 points. And the patients who got the lower dose never reached above 40. So this kind of helped determine the dosing, but also helped get the drug approved. This was the second study that looked at Zolgensma. It was health outcomes in spinal muscular atrophy type 1 following this gene replacement therapy, which was turned out to be Zolgensma. This 12 patients that were confirmed to have type 1 spinal muscular atrophy, it was an open label study between December 2014 to December 2017. They received the one-time infusion and then were followed for 2 years. They were followed for 2 years for the outcomes in pulmonary intervention, nutritional interventions, their swallow function, hospitalization rates, and then motor function. So this was the pulmonary support for these patients. In red, I've boxed off 7 out of 12 of these patients who did not require BiPAP prior to dosing and still did not require it after dosing. There were 3 patients, which I starred, who started the study without BiPAP, but actually ended the study with BiPAP even after receiving the infusion. These 3 patients all had early onset of symptoms and rapid disease progression, which was characterized by diffuse muscle weakness, respiratory insufficiency, and the inability to swallow. But it's important to note that 2 of these patients required BiPAP due to hospitalization for a respiratory infection. So that's also something that to consider with the fact that they needed BiPAP, but it wasn't necessarily for their disease progression, but due to a respiratory infection. And then there were 2 patients who had BiPAP use prior to dosing and still needed the BiPAP after getting the infusion. This is again showing how these medications are not cures. Whatever neuron function and muscle function is already gone, these patients will not get this back after getting this gene therapy. This was the motor milestones that they looked at. The motor milestones that they looked at was bringing the hands to the mouth, head control, rolling over, sitting with assistance, sitting unassisted, and also standing assisted. So 9 out of 12 of these patients received or achieved all of the milestones. 2 of them never were able to roll over, and 1 never got past bringing the hand to the mouth. But what I've boxed off in red here is the most important finding from this study is that 11 out of 12 of these patients were sitting unassisted at the end of this study. Like I said, these are type 1 spinal muscular atrophy patients. And if you remember back to the beginning of this presentation, type 1 spinal muscular atrophy patients are considered the non-sitters. They never reach that milestone. So this finding was incredible and is what truly got this drug approved, because the fact that 11 out of 12 of these patients were sitting unassisted and 4 of these patients were actually standing assisted was absolutely unheard of. This also looked at swallow function and hospitalization. So on the left-hand side, was the swallow function, and as you can see, there was an increase from baseline in the ability of these patients to safely swallow thin liquids and safely swallow to allow for oral feeding. There was a dip in the patients who were exclusively fed by mouth, and this was due to 1 patient who had a gastrostomy placement. This was performed to enhance nutrition and improve wound healing and recovery from a difficult post-operative course after this patient went through scoliosis surgery. So scoliosis is a common complication of patients with spinal muscular atrophy because they lose the muscles that actually help support the spine. So many of them develop scoliosis. That was just something to consider. Small issues like that when you have a small population in the study can kind of skew your data. On the right-hand side, I included this chart because it's actually comparing hospitalization rates during the study to the ENDEAR study, which was the study that got Spinraza approved. And as you can see, more patients who were on Spinraza on that study were hospitalized for more than 20% of their time on the study, where none of these patients in the Zolgensma study needed to be hospitalized that much. That was just something to compare the 2 drugs, which I thought was interesting that they included that. This was actually a follow-up study of the previous study, and I included this study because it actually grouped the patients according to their age at the time they got the dose and their baseline CHOP INTEND scores. So early was considered less than 3 months, late was if they were 3 months or older, and then a low CHOP INTEND score was less than 20 points, and a high was if they were more than 20. Then they divided this up and got 3 groups. So an early dosing with low motor function, a late dosing, and an early dosing with high motor function. Then they took these groups of patients and they graphed their CHOP INTEND scores again. This really is showing how important it is to give these medications as early as possible to maintain the motor function that these patients have. Like I said before, this will not give back any motor function that it's already lost, but it will help to prevent further degeneration. So in orange is our patients who got the early dosing and had high motor function at the time of dose, and they had the highest CHOP and 10 scores, which makes sense. The patients who got late dosing and either had early dosing but the low motor function or lower on the scale. So even if they were dosed early, but they still had the low motor function, like I said, this drug is not a miracle drug that's going to help them regain their neurons. Whatever's lost is lost, but this is just helping solidify the fact of how important it is to dose as early as possible. This again, I just included this chart because it does again group them based on early dosing, and you see in orange, 2 out of 3 of the patients who were early dosing and had high motor function were actually walking independently by the end of this study, which again, these are type 1 patients with spinal muscular atrophy who historically were never able to sit on their own, and now these patients are walking independently. So this was an incredible breakthrough and also helped prove to get this medication approved. I know I just went through a lot of studies and a lot of numbers and charts, but to kind of put a face to this medication, I've included this video here to show you how much of an impact Zolgensma really has had.
Spinal muscular atrophy, or SMA type 1, is the leading genetic cause of death for infants today. A devastating fact this family knows all too well.
Our first daughter, she was diagnosed with SMA type 1 at 6 months of age, and she passed away at 15 months old.
This is a disease that is devastating for infants. A large percentage of patients die before 1 year of age, but 95+% are gone, unfortunately, by age 2.
SMA rapidly robs babies of their ability to move, talk, swallow, and eventually breathe. When Milan and his wife Elena found out they were pregnant with their second child, Evelyn, they prayed for a healthy baby. Unfortunately, that was not the case.
When she was born and the results came back, and found out she was positive for SMA type 1, and we both kind of just broke down. We found out about the clinical trial here at Nationwide Children's Hospital.
This is really the first time that we've been able to apply gene therapy to any neuromuscular disease.
Today was a very special day for Evelyn. She was given genetic therapy for her missing SMN gene.
Babies with SMA are missing a gene vital for development. Through a one-time injection, gene therapy replaces this missing gene. For Evelyn, this gene therapy worked.
We start seeing changes as early as 2 months after treatment.
She started to push, and she started to get more active, holding her head up. And a little after 3-4 months, she rolled over on her own.
Now 3-year-old Evelyn challenges Dr. Mendel to a dance-off at her annual follow-up appointment.
She comes back after 3 years, and she runs up to me and hugs me and says, "Dr. Mendel, I love you."
I forget that she has SMA. This is a healthy girl, and she does everything that a normal 3-year-old child would do.
Something like that has never been achieved before.
Well, with our first daughter, it was just devastating to lose a child. You lose all dreams you had for their future, and now we can actually save for college.
So that really puts a face to the disease and also the treatment, and to show how far we've come. That it also shows how new this treatment is. These parents, this family, sadly had to see the devastating side effects of this disease when there was no treatment. But lucky for them, we have the treatment now, and Evelyn is looking really good. So lastly, the newest medication that was approved for spinal muscular atrophy is Risdiplam. So this was actually approved in August of this year, and it's approved for the treatment of spinal muscular atrophy in all patients greater than 2 months old. The biggest thing with this medication is it's actually a PO formulation. These patients will be getting 1 daily dose for the rest of their life. It's dosed by weight until they're greater than 20 kilograms, and at that point they're on just 5 milligrams once a day for the rest of their life. The dosing for this, the pricing for this, it's actually $167 per ml. So this comes in a 0.75 milligram per ml solution. So that 5 milligram dose that these patients will be getting equates to $628 per day. That equals about $19,000 per month and about $226,000 per year. The way it works, it actually works very similarly to Spinraza. It is a SMN2 splicing modifier. So it increases exon 7 inclusion in the SMN2 mRNA transcripts, and this helps produce full-length SMN protein in the brain. So there's actually 2 studies that are scheduled to be completed in 2023, but the preliminary data from those studies actually got this medication approved in August of this year. The results haven't really been released yet, but I'm excited to see how these studies end up in 2023. So to wrap up, spinal muscular atrophy is an autosomal recessive inherited progressive neuromuscular disorder that results in muscle atrophy. It's a devastating diagnosis, but the research that we have and the current drugs that we have been amazing. The data that we currently have is promising, but the long-term benefits and risks are not known yet because these medications are so new. But gene therapy really has been revolutionary for spinal muscular atrophy, and many disease states are likely to follow. Gene therapy is being studied, like I mentioned before, for all kinds of diseases with no cures right now. So it really is going to be the future of medicine. So at this time, I'll open it up for any questions that you may have. Okay, if there's no questions, you will all be receiving an email with the link to the post-assessment questions. It will also include the CE code for you guys. I'm going to just go over quickly the post-assessment questions now, just so you guys kind of have them set when you get the email.